Systemic lupus erythematosus is commonly examined on medical examinations, and it's also important to know the clinical aspects of it for your practice or even for ward rounds and so on. So in this video, I'm going to cover all the basic things that you need to know. I'm going to give you a good introduction. I'm going to show you how you can remember a lot of these things and try to make sense of a lot of those high yield points that are always tested. If you stick around to the end of the video, I'll show you an important mnemonic that I always use to remember all the clinical features of systemic lupus erythematosus. And let's get started. So the word lupus is from Latin and it means a wolf. So long ago, the doctors, as they were examining patients who had lupus, they found that they have this rash on the cheeks that looked like wolf bites. To me, it doesn't look like wolf bites, but I wouldn't know anything about that. So when you think about lupus, this is an autoimmune disease that is going to be characterized by antibodies to nuclear and cytoplasmic antigens, and it's going to cause multisystem inflammation, a protein clinical manifestations, and relapsing and remitting cause. We're going to have it on and off. We're going to have flares. That is what we are talking about. And the epidemiology is that we're going to have it affecting more females than men, a ratio of 9:1, peaking at around the age of 15 to 45 years. Or the reproductive age, and it is going to be more severe in African ancestry, most probably because of late diagnosis. And in pediatric populations, it's more aggressive. It has a late onset, and when we have a late onset of it, most of the time we have more serositis, so it's going to affect more organs inside. And the major mortality or the major cause of death in people who have lupus is going to be renal disease. They're going to get what we call the lupus nephritis, and then later they may die from cardiovascular disease. And we are going to see this because of that multisystem inflammation or the widespread inflammation. It's going to accelerate atherosclerosis, and they're going to end up with coronary events. So when you look at the etiology, genetically we have some susceptibility when people will look at the HLA-DR2 and HLA-DR3. Then another important one to know is the lack of this complement factor C1q, C2, and C4 deficiency. Deficiency of this is going to be one of the things that are blamed for the etiology of lupus. Then we have environmental factors like exposure to UV light. These are going to cause flares, exposure to Epstein-Barr virus, and smoking. Then hormonal factors like estrogen, and we have seen it's more common in females, moreover the females in the reproductive age. So estrogen has been blamed or has been thought of to be one of the causes. Then we have drugs like hydralazine, procainamide, isoniazid, are going to be also a cause, and most of the time these are going to cause histone positive antibodies to be present, but we shall look at the antibodies later. So when you look at the pathogenesis, most of the time you're going to have a defective apoptotic clearance. So we have cells that are dying, but these cells are not cleared very well. Now, when they're not cleared very well, they are apoptotic, they have already burst, they have released their intracellular components to extracellular. These components are going to be picked up by the B cells. And when B cells pick up these components, they're going to produce autoantibodies against these components. So we have the DNA, dsDNA. These are going to be antibodies against this double-stranded DNA, anti-SNF antibodies, RO antibodies, as well as the antiphospholipid antibodies, which are seen in the antiphospholipid syndrome, which is thought as a subset of all falling under the lupus complex. And we shall look at, I'll talk a little bit about antiphospholipid syndrome and list the important things you need to know. When we look at the immune complex, after we have produced the antibodies, they're going to go and attach the antigens, and you have immune complexes forming within the blood. But these immune complexes are going to now circulate and will be deposited in different organs. The kidney is one of those organs, and the skin, as well as serosha. Then because of this activation of these antibody antigen complexes, we shall have consumption of complement proteins. So the complement proteins are going to go down, that is C3 and C4. So when we look at the clinical features, patients with lupus are going to have a classic triad of fever, a joint pain, a rash, and then you shall have some constitutional symptoms that is going to still include the fever, fatigue, weight loss, and this may occur especially during a flare. Then we have the skin. Most of the time, the most pathognomic sign seen is the malar rash that is going to spare the nasolabial folds. And this is important to differentiate it from dermatomyositis, where we have the rash covering even the nasolabial folds. we're going to have photosensitivity. So most of these lupus rashes are going to be in sun exposed areas. We can have the discoid lesions, or what we call the discoid lupus, and it's sort of to be a kind of a less aggressive form of lupus. We can have oral ulcers occurring, and these are going to be painless, and we can have alopecia, which is loss of hair. When we look at the hematologics, most of the time people with lupus are going to have an anemia, and it can be an anemia of chronic disease, or it can be an autoimmune hemolytic anemia. So the immune system, remember we're having an autoimmune disease, the immune system may recognize red blood cells and affect them, but because of also the chronic inflammation, we have a projection of hepcidin and things like that, we have decreased production of red blood cells as an anemia of chronic disease. Then we can have leukopenia, we can have lymphopenia, and then we can have thrombocytopenia. And when you look at the mastocytosis system, we can have asymmetric, and this is important to know that it's a non-erosive polyarthritis. We are having different joints affected, but it's non-erosive. This is going to differentiate it from rheumatoid arthritis, where we have the immune system affecting that joint space when we have erosion. Then we have the Charcot arthropathy, which is basically the same thing. It's explaining a non-erosive deforming arthropathy. You have the deformity, yes, but it is not erosive. Then the cardiac side effects, we can have a pericarditis, we can have myocarditis, then we have the Liebman-Sachs. Now, Liebman-Sachs is a form of endocarditis where we have this smaller sterile emboli happening in the heart. Then renal is the leading cause of mortality, and it's going to occur in 50 to 60% of people who are having lupus. And it's the reason, and it's going to be characterized by proteinuria. They may have hematuria, they may have red blood cell casts, and they may have hypertension. And we have classes from class 1 up to class 6 as by the ISN or RPS. And most of the time, class 3 and class 4 are proliferative, and you consider them to be the most severe. In third period, we have the membranous, and it's going to cause nephrotic syndrome. Remember the causes of nephrotic syndrome. I made a video about nephrotic syndrome. It's the very first video I made on this channel. You can check it out in my internal medicine playlist. Then we have what we call a full house. Now, a full house is going to occur when we have all the major immune markers. When you get this biopsy from the kidney and you stain it, you do immunohistochemistry, you realize that all the markers for immune markers are there. We have the complements, we have the antibodies, you have everything. The full house, whereby when you do histochemistry after taking the biopsy from this kidney, when you do the histochemistry and you stain, you're going to see that all the immune markers are there, the complement proteins, the autoimmune antibodies are all going to be there. This is what we call a full house. Then when we look at the pulmonary system, sometimes we have pleuritis, we can have effusions, we can have pneumonitis, we can have the obstetric complications, and these are going to be mostly seen in antiphospholipid syndromes, where we shall have recurrent abortions or recurrent miscarriages. And this is going to be related to the antiphospholipid antibodies. Then we have neonatal lupus sometimes, we have the anti-RO antibodies. We have neurological complications or neurological features. Sometimes we have seizures, we have psychosis, we have stroke, we have cognitive dysfunction. So we have the EULAR 2019 criteria that we are using currently, and this is 2026, that we're using currently to diagnosis of lupus or systemic SLE. And it has a few important aspects that you have to understand. I did not put the whole summary here, but I tried to pull out those important details that you should know. So the most important detail, and the first detail, is the entry, and that is the ANA, or the anti-nuclear antibody. This is one of the most sensitive antibodies for diagnosis of lupus. But it is positive even in other conditions. But when it is not positive, most of the time we do not consider this patient to have lupus. So everybody with lupus has to have a positive ANA. Those are titers greater than 1 to 80. So once you get that, or once you check your patient and they have a positive ANA, then you continue to check out the rest of the domains. And when you get points that are greater than 10, that is when you are going to consider this patient to be having lupus. So we're going to have clinical and immunological domains where we shall check for different entities, and these different entities we shall go on compounding the points, adding them together. That is their additive. Now, if If we make 10, then we consider. So I think on the main one, you want to check for fever. Fever will score a maximum of 2. When you look at the blood, the maximum score is 4. Of course, there are different parameters under this. You may find like if you have anemia, score is 3. If you have a thrombocytopenia, score is 4, and so on like that. Then we have the mucocutaneous domain that you also check. The maximum is going to be a 6. Musculoskeletal maximum is 6. So the maximum is 6. Neuro, the maximum will be 5. Then when you look at renal now, renal is different. Renal alone is able to even diagnose someone with lupus, someone with a positive ANA, and they're having a class 3, a class 4, and they're having a class 4, and they're having a class 3 or class 4, and class of SLE nephritis, they're already having a 10. They're going to already be considered having lupus. Then we look at the immunological domain. If you have antiphospholipid, antibodies, that's a 2. Losses 3, C4, so 4. Then double-stranded DNA anti-Smith antibodies are going to give us a 6, so they have a higher kind of specificity. So what is high yield is like lupus 3 and when we have lupus nephritis class 3 and 4, we are obviously at a 10. If we have the ANA is not scored, you don't add it to the points that we use. Then if no ANA, no lupus. So when we look at the lupus antibodies, this is another important thing that you have to understand. We have the ANA, and this is the entry gate, that is the most sensitive antibody that we check for, but it is not very specific, which means it can be positive even in conditions that are not lupus or that are different. Then we have the anti-dsDNA. This is going to be specific, and it is going to be associated with renal risk, and it scores 6 points on the criteria. We have the anti-Smith. These are specific. It's a classic SLE, and it scores also 6 points. Then we have the anti-RO-OSSA antibodies. These are going to be associated with photosensitivity and neonatal lupus. We have the anti-LA-OSSP. These are often with the anti-RO, and we shall have Zika. Then we shall have neonatal risk. Antiphospholipid is going to be associated with proboscis, and is going to have pregnancy complications. Then antihistone is associated with drug-induced lupus. Then we have loss 3C4, that is associated with disease activity, and it scores about 3 to 4 points. If you have one of these, then 3. Then if you have both of them low, then it's 4 points. So we're going to look at the basic investigations. So we're going to do the basic labs. You're going to do the full blood count where you look for cytopenias. You're going to do ESR. You're going to do CRP. You're going to do urea and creatinine. You're going to do urinalysis. Immunology, you're going to do the anti-dsDNA, anti-Smith, complement levels. You do the imaging where you can do an echo if you have cardiac suspicion. You can do renal biopsy and things like that. Then we have differential diagnosis. We can rule out rheumatoid arthritis, mixed connective tissue diseases, dermatomyositis, vasculitis, and infections sometimes, like HIV and TB. So when we look at the management, the general principles are going to include sun protection. We're going to do vaccination, and this is an important thing because most of the time, these people with lupus have a functional asplenia. So we try to vaccinate them against these encapsulated organisms, which they would be susceptible to. You want to treat infections promptly. You want to assess the cardiovascular risk and reduce it. And in rituximab is used in refractory cases. So pharmacological management, you're going to have the mild disease where you shall give the NSAIDs, we shall give hydrochloroquine. And this is going to be the cornerstone for all SLE, unless we have contraindications to hydroxychloroquine. Then in moderate disease, we may add in a steroid that's been solon. We can add on methotrexate and azathioprine. These are the DMARDs, disease-modifying and traumatic drugs. Then in severe disease, we may give a high-dose IV steroids. We can give cyclophosphamide and mycophenolate mofetil. Then the biologics, we can use belimumab. Then when we look at the high-yield pulse, all the things, the takeaways that you should always remember about lupus is that temporal rash that spares the nasolabial folds is pathognomic. Anti-dsDNA is equivalent to kidney involvement. So most people who have anti-dsDNA, kidney. Then anti-Smith is highly specific for lupus. Then low complement is equal to a flare. When someone has lupus and the complement falls down, it means immune activation has started again. Then we have a flare. a young woman with cytopenias plus a rash plus proteinuria, make sure you think about SLE. Drug-induced lupus is going to be associated with antihistone positive SLE. Then always remember SOAP brain MD. This is a mnemonic I use for remembering all the clinical features of SLE, and I posted it on my Instagram. That is made one pager on Instagram. Please do check that out. You will see it. And remember to have a nice day. Remember to stay reading hard. This is made one pager. My name is Benjamin, and let's meet in the next video.